They are fellow podiatrists. Today we will talk to our guest speaker, Dr. Simon Spooner, about the past, present, and future of foot orthosis research. Good morning, Dr. Spooner. It is a pleasure having you with us. How's it going?
Very good, Hola. Thank you for having me here. It's a strange time, but we're getting on and carrying on, and a good time for professional development. Lots of Zoom calls, lots of webinars to watch and keep up to date. So I'm catching up on some of the things I said I should have been doing, but didn't have time because I was seeing patients instead. So it's good. It's a good time to work on our own education.
Okay. As I said before, the title of this interview is The Past, Present, and Future of Foot Orthosis Research. And our first question is, what improvements do you consider could be made to the way that foot orthosis research is performed?
Okay, so we need to sort of think historically as to what has occurred in foot orthosis research to date. And early on, most of the studies that have been performed were on kinematics, looking at positional changes that occur with foot orthoses. And that's common sense, really, because at that time we were using a very much a kinematic paradigm, the root paradigm. So it was obvious that when we started to try and investigate the mechanisms by which foot orthoses were working, we were choosing to look at changes in position and movement, the kinematic studies, and also because they were relatively easy to measure. So we saw a lot of studies coming out on kinematics, and then with the improvements in technology with in-shoe pressure measurement systems, we saw a number of years now of publications looking into changes in kinetics. These are all useful studies. The problem is that what tends to happen is when the data from these studies is analysed, rather than reporting the changes for each specific subject, they tend to be grouped together. So we see sort of mean responses. So, for example, we could have a kinematic study which looked at, let's say, change in rear foot motion with foot orthoses. And we might see what one or a number of subjects have reduced inversion of, say, 2 degrees, and the same number of subjects having increased eversion by 2 degrees. So when we take the mean of the data, what that gives us is a mean of 0, which suggests that the foot orthosis didn't alter the rear foot position. Well, that's not true. That's the statistics hiding the reality. So one of the things I think that it is limiting us is the way in which the data is presented. The other issue is that quite often when we look at foot orthosis research, the orthoses that are being used within the research don't necessarily reflect the kind of orthoses that the clinicians are prescribing for that condition. So, for example, there was a large study in which they were looking at the role of foot orthoses in the treatment of Achilles tendinopathy. Now, if you ask the majority of clinicians, certainly the clinicians that I speak to regularly, about the design features that they would put into a foot orthosis for a patient with Achilles tendinopathy, the vast majority of them would include a heel lift in that device. Yet when the researchers undertook that study, they used foot orthosis that didn't include a heel lift. So there's this mismatch between clinical practice and the way in which foot orthoses are prescribed by the clinician, and the way in which researchers are employing foot orthosis in their studies. And excuse me, my dog's just moving. she just decided that she wants to move. So there's this disconnect. There's this disconnect between the researchers and the clinicians. It's improving. It's getting better because more and more they are bringing clinicians on board within the research designs. But that's one of the sort of the issues.
Yeah.
Yeah. I don't know whether you want me to say any more there, but
yes, I'm sure that will be helpful for many of us. So continuing, if someone doesn't believe in foot orthosis as a therapy, are they destined to fail?
Yeah, this is an interesting question. This is something that myself and my colleague Ian Griffiths, who's I've been Ian's mentor for a number of years now, and he's hoping to undertake his PhD soon. And one of the areas that we're interested in at present is the use of language and its potential effects on the outcomes of foot orthosis therapy. And we have a number of studies, not on foot orthosis, but on other therapies. For example, there was a study of acupuncture by Lind in 2007, and they noted that the beliefs of the patient would impact on the outcome of the acupuncture. So if the patients believed in acupuncture, believed that it would get them better, then they ultimately got better outcomes. Similarly, there's been some studies of kinesiotape where the level of education given to the patient has been shown to impact the outcomes, and also with ultrasound therapy. So if you've got a patient who doesn't believe in foot orthoses, that doesn't necessarily mean that the foot orthoses won't work, but the potential for them to get a positive outcome is probably reduced. But you do get the opposite. I'm reminded of a patient that came in recently, and she got a bag of probably about 10 pairs of foot orthoses, none of which had solved her problem. Yet she came to me wanting me to make some more foot orthoses for her.
Yeah.
So you have to ask yourself, at what point in time do you say foot orthoses might not be the solution to this problem? Yet she firmly believed that they were, because she wanted me to make her more. But there's a complex interrelationship. For many years, we've looked at foot orthoses as these sort of biomedical devices, and the research has focused very much on the biomechanics, on the changes in the biomechanics that occur with foot orthoses. But we employ foot orthosis in this much bigger biopsychosocial network. So we can't ignore the human that's receiving the foot orthosis, and their belief system will ultimately impact upon the outcomes that we achieve as clinicians. And I think it's an area that's desperate for further research, because we've sort of run these controlled trials in which the researchers try to eliminate the psychological components by introducing sham and, quote unquote, placebo foot orthosis. That's a different ballgame. There's no such thing as a placebo foot orthosis, but that they try to remove the psychological component, which is understandable for clinicians, because they want to avoid spurious variables. But as a clinician, what we want to do is embrace anything which is going to improve the possibility of a positive outcome for that patient. So the language that we use when we're talking with patients, the context in which we're setting the foot orthosis off as a therapy, have great potential to ultimately influence whether the patient gets better or not.
Thanks. The last question to you will be what research into foot orthosis therapy would you like to see carried out soon?
I've sort of touched on it there. I'd like to see some more research where we're looking at the use of language, we're looking at other psychological factors. It's interesting actually, because a number of years ago, probably 15 or 20 years ago, one of my undergraduate students, for their dissertation, we ran a trial for patients with plantar fasciitis, plantar heel pain, and they all got the same insole, same design of insole, prefabricated insole, but half of them we gave black insoles to, and the other half we gave green insoles to. And we didn't really get enough subjects within that study to draw any firm conclusions. But there was a definite trend in that the subjects who received the green insoles seemed to be showing greater reduction in their pain scale scores than the subjects that received their black insoles. Now, just last week or the week before, there was a paper published by a group of researchers out of Hong Kong or China, I think, Wang et al. And what they did is they've just performed a study where they compared white insoles with red insoles. And what they found was that the perceived level of comfort was higher in the red insoles, that there were kinetic differences between subjects when they wore the red insoles compared to the white insoles. Now, bear in mind, mechanically, those white insoles and red insoles were identical. The only difference was the colour. What they didn't find was any differences in the kinematics, but then we can have a difference in kinetics without obvious change in kinematics. So I'd like to see more studies done on colour. It's a very, very basic variable that when we're manufacturing foot orthoses, we choose a coloured foam, we choose a coloured plastic, and we give them to our patients. And there's very little thought goes into why we're choosing that colour. It's just whatever colour plastic happens to be on the shelf. But I think when we start looking at foot orthosis therapy from this broader psychosocial perspective, then we can see that variables such as colour might be significant. You know, the pharmaceutical industry, they've known about this for years. They don't make tranquilizer pills in red because that's not going to make you more tranquil. They tend to make them blue. So it would be interesting to see some studies where, you know, perhaps if we think about patients when they present with pain and inflammation, you know, is heat. Now, if we think of a colour that we associate with heat, it tends to be reds and yellows, oranges. So maybe they would respond better to a blue orthosis, which is a colour we associate with cooling. So there's a lot of work that needs to be done. But those kind of things, I'd like to see all sort of research studies now where we've got subjects. I'd like to see data for those individual subjects reported. Stop meaning it all together because it loses its meaning. We know that you know, we're all individuals. We all have a different genotype, and when we put a foot orthosis in, even if we're using a prefabricated orthosis, if we have a study where everybody gets the same device, to expect all those different genotypes to react the same is utter madness. You know, that's not how the world works, and we know that. which is why for a long time when we got bogged down with the routine model, this expectation that there was somehow some ideal norm that everybody should fit into this box. When you view that through a critical mindset, it's obvious that can't possibly be right. So equally, when we put orthosis into a group of subjects' feet, why on earth would we expect them all to respond the same? Mm-hmm. So rather than pooling all of the data together and losing the intra-subject responses, report the data for each of the subjects in the study. You know, most foot orthosis studies, they have 20, maybe 30 subjects in them. So you do get some larger ones, but generally speaking, there's no reason at all why the individual data can't be reported within that paper.
Okay, interesting, Dr. Spooner. So, do you want say anything else or about this topic?
One of the areas that I'm interested in addition to this, is this sort of the indirect neuromotor response of foot orthosis. So, if we think about foot orthosis, again, most of the early research has focused on this direct mechanical response of the body when we put a foot orthosis in situ. But we also get these sort of neuromotor indirect responses, which we're starting to pick up on using EMG studies. So there was a study by Annie Munderman around about 2006, I think. 2006, her EMG study when she was doing a PhD. So what they did there was they looked at different orthosis designs and their effects on the muscle activation. And what she found was that when they used a highly inverted foot orthosis, the peroneal muscles start to fire. So this seems to be a sort of protective response to stop the foot, or to stop the body being injured through an inversion injury when the foot orthosis is pushing too hard. So this is one of the things that I'm sort of interested in at the moment. There was another study published in Journal of Foot and Ankle Research a couple of years ago by a chap called Ludwig, where they used these insoles, these foot orthoses, with I'll find a link if you like, but they've got this pressure point up against the cuboid in the area of the peroneal notch. And again, what they found was that when they put that insole in situ, the peroneal activity increased. Now, on first examination, you think, well, how is that pressing against the where the tendon runs, causing an increase in peroneal firing? But actually, I think what's happening there is that insole is, because we have to think of force as a vector, right? Although the sort of modification is sitting on the lateral side of the foot, it's probably creating an increase in external supination moment. So the body is reacting to that by firing the peroneals to prevent injury. So there's this whole area around the sort of central nervous system and its response to foot orthosis. And before we got locked down for coronavirus, one of the things that we were trying to do was to collect some data pre and post tibial nerve block. So looking at the 3D kinematics and some in-shoe pressure with various foot orthoses, then put in a posterior tibial nerve block to see if that data changed. And unfortunately, this virus came along and stopped that research project in its tracks. So that's one for another day, I think. But that's an area I'm interested in and investigating at the moment.
Well, Thank you very much, Dr. Spooner. It has been a very interesting, and I am sure everyone could learn something new for your answer. Okay. So finally, we would like to ask you to give a message of encouragement to all podiatrists, please.
Okay, everybody, stay safe. Keep thinking positive thoughts. This will not last forever. Keep working hard, keep studying, and we will be getting through all this all together, and we will get back to, well, let's not get back to how life was. Let's make the world a better place. Okay, so pongamos al mundo de pie.
Thank you so much, Dr. Spooner. Take care.